Hello, and welcome to the RadioGraphics Podcast. My name is Anna Sophia McKenney, PGY5 R4 resident in the Integrated IR-DR program at New York Presbyterian Weill Cornell Medical College in New York City. I've also had the pleasure of working as a part of the RadioGraphics Junior Editorial Board, or RG team, for the past 2 years. I'm excited to be hosting the RadioGraphics Podcast, substituting in again for Dr. Gibbs and Dr. Frederick this week, and highlighting a few of the features in our October 2022 Interventional Radiology themed monograph. Today we will be discussing the piece, Vascular Anomaly Syndromes in the ISSVA Classification System, Imaging Findings and Role of Interventional Radiology in Management. We have here today the first author of this paper, Dr. Mindy Wang, an R4 Chief Resident at the University of Texas, Houston.
Thank you so much for having me. I'm very grateful for this collaborative effort with colleagues from all over, including those from Texas Children's Hospital, MD Anderson Cancer Center, Yale University, Mallinckrodt Institute of Radiology, Alexandria University, and Northern Arizona University.
Welcome. This article will discuss the key diagnostic imaging features of vascular anomalies, the role of IR in their management, and it will describe several vascular anomaly syndromes in the 2018 ISSVA classification system. Mindy, do you think you can start us off? Tell us a little bit about the ISSVA classification?
Sure thing. Historically, vascular anomalies have been referred to by their vernacular names, which has led to misdiagnoses and inappropriate management. This classification system for vascular lesions was introduced in 1982. These have been characterized according to their endothelial characteristics, either as hemangiomas or vascular malformations. This two-class system was adopted by International Society for the Study of Vascular Anomalies, or ISVA, in 1996. This has been periodically updated and most recently revised in 2018. This has been guided based on advances in clinical, radiologic, histopathologic, and molecular knowledge. The ISVA classification is divided into vascular tumors and vascular malformations, with multiple subcategories in each. Vascular tumors are a result of neoplastic proliferation of vascular endothelial cells, while vascular malformations are non-neoplastic structural anomalies. Another way to conceptualize this is to distinguish high-flow versus low-flow anomalies. Simply put, high-flow anomalies have robust arterial flow, while low-flow anomalies do not. Although this is not used by the ISVA classification, this is one approach radiologists can use to initially characterize these anomalies before diving into the ISVA classification. The ISVA classification is more commonly used across multiple specialties, including those outside of radiology. So in a sense, it's a common language used across multiple disciplines. These anomalies can occur as isolated lesions or in association with complex syndromes. These syndromes often develop in childhood and require multidisciplinary management. And therefore, both diagnostic and interventional radiologists have important roles in the care of these patients.
That was a great introduction. Thank you. Now let's dive into the imaging of some of the more common vascular anomalies. Ultrasound and MRI are going to be the first-line imaging modalities for identifying, characterizing, and evaluating the anatomic extent of both vascular malformations and tumors. On ultrasound, grayscale can be used initially to provide clues about which type of lesion is present, while, as we all know, dynamic imaging can help differentiate from other lesion types. Using color and power Doppler ultrasound can aid in defining their hemodynamics, and contrast-enhanced ultrasound can help visualize poorly defined lesions, and it can also be used for interventions. MRI allows for additional tissue characterization. It also allows one to more confidently establish extension of lesions to adjacent critical structures, for example, the orbit or the spine. MRI angiography and dynamic perfusion can serve as adjunctive examinations in these situations. Other imaging modalities may be used, for example, if there is a contraindication to MRI or if a vascular anomaly is not yet suspected. For example, plain radiographs are often obtained initially for the assessment of nonspecific symptoms. In this case, the primary role of the radiograph is to exclude common conditions. However, they may provide an additional clue to diagnosis, including the presence of soft tissue masses, phleboliths, or bony changes. CT can be used in this scenario or when MRI is contraindicated. One might also use conventional catheter angiography or direct percutaneous phlebography in diagnosis or especially in planning interventions. Time-resolved CT angiography, or four-dimensional CTA, is an additional option. Finally, there's been renewed interest in molecular imaging, as knowledge of the molecular pathways of vascular anomalies has advanced over time. The development of new radiotracers can aid in diagnosis of certain malformations and if they respond to systemic therapy. Now, when we're evaluating and describing these images in diagnostic settings, we can think about the classification, as Mindy mentioned, in terms of high-flow and low-flow vascular anomalies. In the high-flow vascular anomalies, we're really talking about robust arterial flow. The first major anomaly in this category is the arteriovenous malformation, or AVM. This is defined as a dysplastic artery that shunts into arterialized veins through a vascular nidus. These are characterized by enlarged serpentine vessels with flow voids. They demonstrate early opacification with contrast, have multiple enlarged feeding arteries, and exhibit early filling of those draining veins. Low resistance, high amplitude waveforms will be noted in the arteries, while arterialized flow will be observed in the draining veins. On ultrasound, one will see color Doppler aliasing due to turbulent flow in the nidus. The next major anomaly in the high flow category is arteriovenous fistula. This is a direct connection between an artery and a vein without a nidus. Finally, a vascular tumor such as congenital hemangioma will have similar features to an AVM, except there is a lobular morphology and an enhancing soft tissue component to the lesion. Moving on to low flow vascular anomalies. These malformations will not have a robust arterial flow. The first major category is venous malformations. And these can have many different morphologies, ranging from small and well-circumscribed to larger infiltrative lesions. Venous involvement will be characterized by phleboliths, hemosiderin, or thrombosis. And of note, in dynamic imaging, the morphology of the lesion may be responsive to the Valsalva maneuver. Next, lymphatic malformations are anomalies of the lymphatic vasculature. They result in absent or incomplete lymphatic drainage, and manifest as fluid-filled masses, usually with peripheral rim enhancement and without central enhancement. They can be classified as microcystic, in which the cysts are so small that the lesion will appear hyperechoic on ultrasound, or macrocystic, defined as greater than 1 to 2 centimeters, which will contain hypoechoic cystic structures, and because of their size, debris or an internal hemorrhage may be more apparent. Of course, mixed macro and microcystic lymphatic malformations can also exist. Finally, in low-flow malformations, capillary malformations are usually noted on the clinical exam first as cutaneous red discolorations. Imaging's role in these cases is primarily to evaluate extent. Now, radiologists can be involved in both diagnosis and management of these vascular malformations. Mindy, do you mind telling us a little bit about how this looks at your institution?
Certainly. So, first off, vascular anomaly syndromes do require highly specialized multidisciplinary management, and IR is a critical part of this. At Texas Children's Hospital, we do have a dedicated vascular anomaly clinic. We receive referrals which are first screened by our medical and surgical clinic directors. Ideally, there should also be an IR director. These directors help determine if the patient would be seen by certain subspecialists, such as those in dermatology, hematology, or surgery. Unless only managed medically, patients are generally always cared for by radiologists, as we help provide diagnostic interpretations of imaging studies. Our vascular anomaly clinic takes place every week. However, this can greatly vary by institution based on the need and volume. So now let's discuss some common IR techniques used to treat these anomalies.
Great. Let's begin with venous malformations. So in the case of symptomatic venous malformations, sclerotherapy is the primary approach that's used. In this procedure, we maximize the concentration and duration of a sclerosing solution in the endothelial vessel lumen in order to destroy the vascular endothelial cells. A common agent is concentrated ethanol, which induces protein precipitation and results in cell dehydration, apoptosis, and vascular thrombosis of the lesion. Complications of systemic administration do include compartment syndrome, arrhythmia, pulmonary hypertension, and hemoglobinuria, so that's to be avoided. Sodium tetradecyl sulfate, or STS, and polydocanol are additional agents that may be used in sclerotherapy. These are safer than ethanol, but they are less potent. Additional, less potent sclerosing agents include bleomycin, moroate sodium, and hypertonic saline. So to begin the procedure, general anesthesia or conscious sedation may be used depending on the sclerosant and the patient's age. Ultrasound guidance is used to introduce a needle or cannula into the malformation, and iodinated contrast material is injected under fluoroscopic guidance to confirm the needle placement. Additionally, it's necessary to identify communication with the normal draining veins if present. A second cannula or needle may be used additionally for decompression. A foam sclerosant is usually administered. This is done to increase the surface area and dwell time in order to maximize treatment efficacy. It can be produced using the Tessari method by mixing STS with ethidized oil in 2 syringes with a 3-way stopcock. Therapy is considered completed when one sees complete filling of the abnormal channels, there is lack of aspiration of blood, there's visualization of the injected sclerosant through the second needle or cannula, or when the lesion becomes firm with gentle palpation. The procedure should be stopped immediately if there are any signs of ischemia change, such as overlying whitening of the skin or overlying tissues. Or if there is drainage observed into normal veins, the procedure should be stopped. Coil embolization between the malformation and the normal draining vein may be performed to prevent complications like these. Post-procedural care may include NSAIDs for pain and inflammation, and steroids can be considered for larger lesions with more swelling. Fibrosis will generally continue for 1 to 2 months after treatment, and follow-up should be performed every 2 to 3 months depending on the clinical scenario. Beware, because sclerotherapy of extensive lesions with high thrombotic load may precipitate deep venous thrombosis or pulmonary embolism. So patients should be screened for intravascular coagulopathy and treated with prophylactic anticoagulation to prevent complications. In terms of lymphatic malformations, these should be addressed if there are repeated infections or hemorrhage within the malformation, there is an aesthetic concern, or if the lesion causes functional impairment or limits quality of life. Microcystic lymphatic malformations are usually treated conservatively because sclerotherapy has mixed outcomes. However, macrocystic lymphatic malformations are usually treated with sclerotherapy. Some options do include interstitial bleomycin or radiofrequency ablation, and in the case of malformations that are associated with superficial cutaneous vesicles, laser therapy can be considered. When performing sclerotherapy, agents for lymphatic malformations are similar to those used for venous malformations. In the case of sclerotherapy of these macrocystic lymphatic malformations, under ultrasound, the cysts are identified and similarly cannulas are inserted. However, cysts are aspirated before injecting the sclerosing agent and contrast material. This is in contrast to the venous malformations where aspiration is not performed at this stage. Sometimes large lesions are treated in multiple sessions over several days, and common post-procedural complications include pain, inflammation, and edema. Patients who do have potential airway compromise due to malformations in the head or neck should have planned post-procedural intubation in the ICU until that airway swelling is reduced. Finally, in the setting of arteriovenous malformations, now we're talking about a high-flow lesion. These are primarily treated by destruction of the nidus with transcatheter or direct percutaneous embolization or alcohol sclerotherapy, or surgical resection in combination with these techniques. These are high-flow malformations, so they can significantly dilute the embolic agent and shorten its transit time through the target vessel, thus reducing its efficacy. Nidus-specific access is an approach that delivers the sclerosant transarterially with the use of a superselective microcatheter technique or direct puncture of the nidus, or sclerosant may be delivered in a retrograde manner using a transvenous approach and a balloon occlusion device. Flow reduction techniques are another approach which block the arterial inflow or venous outflow during embolization. One may use balloon occlusion catheters, tourniquets, pneumatic cuffs, or permanent occlusion with coils to stop those collateral venous pathways. Finally, briefly about vascular tumors, embolization can be used for hemangioma in the appropriate clinical scenario. Additionally, one may use percutaneous ultrasound or CT-guided cryoablation, and this technique has been used for the treatment of hemangioendothelioma. All right, that was a brief description of some common techniques IR might use for these anomalies. While these anomalies may occur in isolation, there are many clinical syndromes with which they might be associated. Mindy and I have chosen a few to discuss today. We strongly recommend that you reference the full article available on the RadioGraphics website for great images and detailed descriptions of these entities and more.
All right, now let's talk about some clinical syndromes associated with vascular malformations or vascular tumors. These can be inherited or occur sporadically. In conjunction with other subspecialists, both diagnostic and interventional radiologists can make a huge impact on these patients' care. From an IR standpoint, we often do not aim for a cure, so setting expectations with the patients initially is very important. In our experience, approximately 45% of patients become pain-free for years, 45% have temporary pain relief, and 10% have no response to treatment. So setting expectation that these are lifelong processes is very important in terms of management. Now, let's dive into the vascular anomaly syndromes that fall under the ISSVA classification of simple vascular malformations. First off, hereditary hemorrhagic telangiectasia, or HHT. This is a generally autosomal dominant disorder characterized by telangiectasias and AVMs. Classic clinical features include recurrent epistaxis, dermal mucosal telangiectasias, solid organ AVMs, and history of HHT in a first-degree relative. There are multiple genetic mutations that are associated with this disorder that have been found to result in abnormal angiogenesis. Complications are often related to AVMs, and they include transient ischemic attacks, strokes, cerebral abscesses, hypoxemia, and high output heart failure. Therefore, screening for pulmonary and cerebral AVMs is recommended in asymptomatic children with HHT. For pulmonary AVMs, embolization is performed in all adults and in symptomatic children with a large bleeding artery that is greater than or equal to 4 millimeters. These patients are at risk for paradoxical embolus, so pre-procedural intravenous heparin is recommended. Coil embolization should be performed with care to stay in close proximity to the nidus. Using a vascular plug is also associated with good outcomes. For cerebral AVMs, this can be treated with surgical resection, stereotactic radiosurgery, or embolization. However, for liver AVMs, embolization is relatively contraindicated due to potential complications, including hepatic infarct and necrotizing cholangitis. Next up, blue rubber bleb nevus syndrome, another disorder that falls under the ISSVA simple vascular malformation category. This is a rare, generally sporadic disorder characterized by multiple venous malformations involving the cutaneous, gastrointestinal, and musculoskeletal systems. On physical exam, one can appreciate soft elevated lesions on the skin or just under the skin that are dark blue, purple, red, or black in color. Activating mutations in the tyrosine receptor kinase gene have been found to be associated with this disorder. That results in unregulated angiogenesis. Additionally, PIK3CA mutations are implicated. Recurrent hemorrhage and pressure on adjacent bone can actually result in limb overgrowth or undergrowth, abnormal bowing, coarsened trabeculate, and cortical remodeling. Complications may include anemia, coagulopathy, gastrointestinal bleeding, and intussusception. Treatment options can include laser therapy and sclerotherapy for cutaneous venous malformations. And for gastrointestinal tract venous malformations, treatment options include endoscopic band ligation, laser photocoagulation, argon plasma coagulation, or sclerotherapy. Next up, We will discuss the Gorham-Stout syndrome. This is a disorder that falls under the ISFA simple vascular malformation as well. This is a non-hereditary disorder that is characterized by proliferation of lymphatic vessels. Features include chylous effusions, ascites, multiple macrocystic lymphatic malformations, and osteolytic lesions. Main complications seen in this syndrome include pathologic fractures and significant functional impairment. Unfortunately, the pathogenesis is unclear, but vascular endothelial growth factor C has been implicated. IR is typically involved in the drainage of the pleural fluid and pleurodesis.
That was wonderful, thank you. Now, the ISFA vascular malformations can also be associated with other anomalies. Once again, these are just a few of the clinical syndromes that are described in detail in the original piece. I'll start with Klippel-Trenaunay syndrome, KTS, or also called capillary venous lymphatic malformation with overgrowth. This is a congenital disorder as a result of a sporadic mutation and is part of the PIK3CA-related overgrowth spectrum, or PROS. There are 3 hallmark manifestations. The first is capillary malformations covering a large area of an affected limb. This is the most common abnormality, and it may occur in any part of the body, but it is often found in a lower extremity. The second is vascular malformations, as we've been discussing today. And the third is bone and soft tissue hypertrophy. Of note, a persistent embryonic lateral marginal vein, or vein of Servelle, is characteristic. The pathogenesis is unclear, but it may involve abnormal vasculogenesis in embryonic development or may be a mesodermal anomaly in development. Imaging evaluation should include radiographs to assess limb length discrepancy, body hypertrophy, and phlebolyths. Additionally, soft tissue findings and vascular anomalies should be evaluated with other modalities. Of note, this is a similar entity to Parkes-Weber syndrome, which we will discuss next. But keep in mind that Klippel-Trenaunay syndrome will have embryonic veins and will not have AVFs. Treatment of KTS, the patient should be monitored closely for DVT. Sclerotherapy can help treat pain or inflammation if the deep venous system is intact. And symptomatic ectatic veins can also be treated with endovascular laser therapy, radiofrequency ablation, sclerotherapy, and/or soft tissue debulking. Pulse dye laser therapy is the standard treatment for those capillary malformations in the skin. This may be a good time to mention that there is another feature in this radiographics issue that focuses on KTS. Next, Parkes-Weber syndrome is a rare congenital syndrome that consists of capillary malformations and limb overgrowth and is therefore often misdiagnosed as KTS. However, these patients typically have arteriovenous fistulas, which are high-flow vascular malformations. This is a predominant feature that distinguishes the two entities. Usually, Parkes-Weber will have numerous small periarticular AVFs in the affected limb. Biologically, a mutation in the angiogenic RASA1 gene is implicated, but the pathogenesis is not well understood. Imaging evaluation is similar in that radiography should be used to evaluate hemihypertrophy, and AVFs in the periarticular regions will be uniquely seen in PWS. Treatment should be focused on potential manifestations of the disease, such as hemorrhage, distal arterial ischemia, refractory skin ulcers, and high-output heart failure. High-flow anomalies may be embolized, varicose veins can undergo sclerotherapy or embolization, and in cases refractory to embolization, limb amputation may be indicated. Finally, let's discuss an ISFA vascular anomaly that is associated with platelet count or coagulation disorders. The Kasabach-Merritt phenomenon, usually associated with caposiform hemangioendothelioma or KHE, is a life-threatening scenario that manifests with severe thrombocytopenia in the setting of an enlarging vascular tumor, which is usually a KHE. This tumor has a distinctive infiltrative pattern and is associated with destructive bony findings. This phenomenon can also be associated with tufted hemangiomas. In this situation, treatment of the mass often corrects the coagulopathy. Complete surgical resection is ideal but not always feasible. Other treatment may include steroids with or without vincristine or sirolimus, and in extreme cases of bleeding, embolization can help prepare for surgery. cryoablation has recently been shown to be feasible and effective as a second-line treatment in this phenomenon. Just to wrap everything up, the ISFA classification system of 2018 is important to understand and reference when there's concern for a vascular anomaly. IR can perform embolization, sclerotherapy, and image-guided ablation in these scenarios. There are numerous syndromes that manifest with these vascular anomalies, many of which affect multiple organ systems. The genetic basis of these syndromes is constantly evolving, and highly specialized multidisciplinary management of these disorders is essential. Do you have any other thoughts you'd like to add, Mindy?
Of course. So, radiologists certainly have a critical role in the diagnosis and treatment of vascular anomalies. Although these syndromes are rare and our interventions are not curative, we can potentially help with their pain control and ultimately improve our patients' quality of life.
That's wonderful. Thank you so much. Again, we've been speaking with Dr. Mindy Wang from the University of Texas at Houston, discussing her recent paper in Radiographics, Vascular Anomaly Syndromes in the ISFA Classification System, Imaging Findings and Role of Interventional Radiology in Management. I'm Sophie McKenney from NYP Cornell and the Radiographics Junior Editorial Board, RG team. We hope that you will access this and many other resources on the RSNA Journal website, pubs.rsna.org.